Well, I want to welcome to the Hurley Comprehensive Weight Loss Center. I am Jennifer Demerly. I'm the manager of the center, and we are glad you're here. I want to talk to you a little bit about the epidemic of obesity. Obesity has reached epidemic proportions and is a major cause of death. It directly affects many major organs, and it's linked to severe chronic health conditions, things like diabetes, heart disease, and even cancer. A lot of times people think that eating too much, not moving enough are the causes of obesity, but actually there's many causes of obesity. It's not as simple as eat less and move more, the solution that is. An inactive lifestyle is definitely a factor. Lifestyles have changed over the past 50 years. You think about desk work, more sedentary work versus, farm life or more active labor. There have been technological advances that have led to more non-physical jobs, so that's really impacted health over the last several decades. Genes and family history also plays a role. Genes can affect the amount and location of fat that's stored on the body. Families also tend to share food and physical activity habits. If you grew up in a household where there wasn't a lot of home cooking that was done and maybe people relied on more takeout food or packaged foods, then someone might grow up not really learning how to cook. If you grow up in a household where physical activity on the weekends or after school wasn't something that was valued and participated in, then they might not grow up with those physical activity habits that are important for good health. There's also some chronic health conditions that can affect and even cause overweight and obesity. Things like underactive thyroid, Cushing's syndrome, and polycystic ovarian syndrome, just to name a few. There's medications that people can take for chronic health conditions that can also slow the rate at which your body burns calories. They can increase your appetite, and they can cause your body to hold on to extra fluids. That, again, can lead to overweight and obesity. Our environment plays a very significant role in obesity. It caters to unhealthy lifestyle habits. If you think about it, a 99-cent heart attack is on just about every corner. Inexpensive processed food is everywhere. Advertising for these foods. Think about the last time you might have watched a primetime television show. How many commercials did you see for fast food restaurants? Sugary drinks. Portions are much, much larger than they used to be. If you look at the two burgers here, 20 years ago, a typical hamburger at a family restaurant weighed in at around 300 calories. Today, a typical burger weighs in at around 600 calories, and honestly, you can go significantly higher depending on the type of burger you're getting. But even that calorie difference can lead to, and just that's one part of one meal. We're not talking about the fries or the soft drink that might accompany it. So even just that calorie difference and the type of calorie that's being provided in some of these foods can lead to significant weight gain year after year after year. There's several different treatment options for obesity. The goal ultimately when you're treating obesity is to reach a healthy weight and, more importantly, to maintain that healthy weight. So there's medical weight loss. That's one treatment for obesity. That includes things like dietary changes, increased exercise, making changes in your daily behaviors, and it could include prescription weight loss medications. There's weight loss surgery. That's something that should be considered when other methods to lose weight haven't worked. So here at Hurley, we have a non-surgical medical weight loss program. It's a 12-week program, and it uses meal replacements based on the 4 pillars of weight management. So we include nutrition, physical activity, behavior change, and medication if needed. We also offer several surgical options, and next you're going to hear from Dr. Wong, one of our surgeons, to describe those in greater detail.
So I'm going to go through the surgical options and kind of briefly describe what they are, what they entail, the benefits, obviously, of all the surgeries that we offer here at Hurley. And if you have questions, we can get those answered at the end, all right? So the Roux-en-Y gastric bypass has been around the longest. The reason why it's the gold standard is because all other surgical procedures are compared to this one, since it has the largest number of patients that have undergone this surgery. Now, as you can kind of see just by the picture itself, right, this is a pretty complicated surgery. So the benefits of the Roux-en-Y gastric bypass is it's not only a restrictive surgical procedure, meaning it restricts how much you can eat, but it also is a metabolic surgery in terms of it changes how your body digests and absorbs fat and sugar, all right? So the benefits of the surgery, you get rapid initial weight loss. Now, again, that's rapid comparatively to some of the other surgeries. We'll talk about a little bit of the next surgery, the data on that. It can dramatically improve blood sugars, especially in type 2 diabetic patients. And again, this is because that metabolic portion of the surgery in which the body absorbs fat and sugar. And it does not require any implantation of any foreign body, like a gastric band, or any post-operative adjustments in terms of like filling and unfilling, all right? Some cons of the surgery, you can get dumping syndrome. Dumping syndrome is typically when you eat large carbohydrate meals, things like that. You get the flushing symptoms, and a lot of that is just changing how the order in which you eat and the amount. There's always a risk for anything that has an anastomosis, and an anastomosis is a connection between either the stomach, which is right here, and the intestines. You have two anastomoses, so that's always a potential for a leak. With the Roux-en-Y gastric bypass, there's always a risk for what's known as a marginal ulcer or stricture, which is an ulcer here where you have a lot of stomach acid coming into the intestines that potentially can cause problems. And then obviously with the bypass, right, so you're bypassing a portion of your normal intestines, there are nutritional deficits that you're going to undergo. So patients require taking long-term vitamins and supplements and things like that to make sure that they're corrected, all right? So as I said, the Roux-en-Y gastric bypass, what we do typically is we cut and make the stomach much smaller. The normal gastric pouch here, which is what we call that, holds typically about 30 to 60 milliliters of fluid at a time, so a very small amount. We connect the small intestines right here, which is known as the roux limb. This is the food limb, so when you eat, the food goes into the gastric pouch and comes down that roux limb. We leave this portion of your stomach in, so that's the remnant stomach. This is where all of your digestive enzymes come down, and this limb is known as the biliopancreatic limb. And this eventually connects to that roux limb, which is known as the jejunal anastomosis, or the JJ. So when you eat, eventually all that food comes down. All those digestive enzymes eventually come down here, and this area beyond this anastomosis or connection is known as the common channel, and that's where all the digestion absorption occurs, all right? Typically, we make this roux limb about 150 centimeters. Typically, we make this biliopancreatic limb anywhere from 50 to 75 centimeters, meaning we typically have anywhere from 200 to 250 centimeters of small intestines left in which your body absorbs all the nutrition, all right? Typical patients, if they've not had any bowel resections, usually have anywhere from 600 to 500 centimeters of small intestines, okay? The next surgery is the vertical sleeve gastrectomy, or the sleeve gastrectomy. This surgery became popularized after a lot of patients underwent a two-stage surgical procedure, and that two-stage surgical procedure was the biliopancreatic duodenal switch, which if any of you guys have ever watched the My 600 Pound Life, Dr. Now, who's down in Texas, that is one of the surgical procedures he's like famous for, like really pushing for a lot of patients that are super morbidly obese. They have a lot of weight loss, and they would actually do that surgical procedure first, and then usually 6 months to a year later, they would go back and do the duodenal switch. And obviously what they found is a lot of patients lost a lot of weight just with the sleeve gastrectomy itself. So what the sleeve gastrectomy is we basically resect, cut out 75 to 80% of your stomach, make it into a long, narrow tube with a linear stapler device. You maintain your normal stomach architecture and the pylorus, which is the normal emptying of the stomach. The stomach itself typically holds anywhere from 60 to 90 milliliters of fluid at a time postoperatively. It can stretch up to a year, year and a half, 2 years out, up to 110, 120 milliliters. It is the most commonly performed surgery in the U.S. right now. About 75 to 80% of patients in the U.S. undergoing weight loss surgery are getting a sleeve gastrectomy. It's a very common procedure outside of the U.S. for like medical tourism, for patients that go to like Mexico and things like that. The intestines are not removed or bypassed. There's no risk of dumping syndrome, and again, that's because you have the normal emptying of the stomach. So a lot of the architecture of the stomach, which slows everything down, you don't have that rush of carbs and things like that into the intestines. Does not require any implantation of foreign body or gastric as a gastric band. It can worsen acid reflux. So that's something that a lot of the times we screen for in patients. Now, reflux is a multifactorial thing. It can be caused simply by just being overweight. Doesn't necessarily have to do with anything of hiatal hernias or any of those things. But patients who have severe acid reflux may potentially get worsening reflux. So that's something that in the clinic we talk to you about and really kind of make what options there are. All right. Small risk of strictures and leaks due to the length of the staple line. Again, that percentage is incredibly low, less than 5% or less than 1%, depending on the studies and everything you look for. Nutritional deficits can occur, but are less likely because, again, we're not removing a lot of the small intestines. What the nutritional deficits are all things related to the stomach acid, and what the stomach does in terms of vitamin D, iron, folate, all that stuff. Okay? As I said, the big thing about the Roux-en-Y gastric bypass and the sleeve gastrectomy, so a fair amount of studies, especially out of the European data, compare that the 1 year average weight loss is about the same between the sleeve and the Roux-en-Y gastric bypass. What you see is more weight loss with the Roux-en-Y gastric bypass that second year. So a lot of the times patients will kind of plateau the first year with the sleeve gastrectomy, and the Roux-en-Y gastric bypass patients will continue to lose weight and overall lose more weight, more body percentage than the sleeve gastrectomy. Okay, so that's kind of when you see the pictures and like that, like in your head, like, wow, that's a more complicated surgery. Why do I want that type of thing? That's where there are some benefits, and especially when it comes to type 2 diabetes as well. All right, the third procedure, which I'm pretty supportive of just because I'm one of the only surgeons that does it here at Hurley right now, is this super long and complicated acronym, which stands for a single anastomosis duodenal ileostomy with sleeve gastrectomy. So this is similar to what's known as the biliopancreatic duodenal switch, that two-stage procedure we talked about with the sleeve. The difference is that we only do one anastomosis, okay? So it's a sleeve gastrectomy similar to the vertical sleeve gastrectomy. Just beyond the pylorus, we cut the small intestines, the duodenum, and we bring up 300 centimeters from your colon over here on the right side, and we sew the small intestines to the duodenum, or just beyond the pylorus, and it creates this basically long omega loop, all right? So when you eat, the food goes down the stomach into the small intestines, and then it has 300 centimeters to absorb. So what we see in these patients, they actually lose more weight than the gastric bypass patients and the sleeve gastrectomy patients. Again, you get an improvement in the blood sugar levels for type 2 diabetics. Very low risk of the dumping syndrome because, again, you maintain the normal stomach architecture with the pylorus, so the food doesn't like dump into the intestines. This is a relatively newer surgical procedure. A lot of it is because of the advancements with minimally invasive surgery. It makes this surgery much easier to do robotically and with laparoscopic instruments that you can sew, which decreases the risk of strictures here at the anastomosis. Again, there's always a risk for leak or strictures. Rare, but they can happen. And again, obviously, nutritional deficits that can occur with the large amount of small intestines that is bypassed. And again, similar to the Roux-en-Y gastric bypass, you're on lifelong supplements. Now, these patients significantly lose much more weight. And again, this is one of those surgical procedures that the patients are really looking to lose a lot of weight, and they have a lot of weight to lose. This is a good procedure because it's safer than the Roux-en-Y gastric bypass studies have shown, and they have less complications because of you maintaining the majority of your stomach as well. All right. The last surgical procedure that we offer here at Hurley is the adjustable gastric band. This has been around for probably about 20 plus years. Basically, this is a foreign body that is put in at the GE junction just below at the top of the stomach. It is adjustable. There's an inflatable balloon within the band itself. In terms of like how it works, obviously after the initial swelling and everything like that occurs after the initial surgery, then you come in and you get the balloon slowly blown up to the point of restriction, and then it's adjusted. It's one of those surgical procedures that, again, it's been around for a while. There are lots of data center studies showing that this is very popular, was very popular. It's kind of becoming a little bit less popular now with the indication for the vertical sleeve gastrectomy and the number of patients that are undergoing that. Just because, again, putting in a foreign body, there are a lot of complications that can happen. It is removable, as you can expect. The intestines are not removed or bypassed, so there's no risk of dumping. Again, you're not cutting anything, you're not manipulating anything, you're just putting in this band. It does require an implanted medical device, so again, any foreign body is at risk for infection or erosion or anything like that. It's a much slower, less weight loss compared to any of the other surgical procedures, just because, again, it's restrictive, but it doesn't really completely restrict the other portions of your stomach. It's just initial. There's risk of band slippage or erosion, which does often require reoperation. And it requires frequent routine adjustments. So patients require a lot of post-operative visits for adjustment of the band. Okay. Recovery time. So all these surgical procedures, we typically try to discharge the patient within the first 23 to 48 hours. So it's typically a 1 to 2 days in the hospital. Again, the whole point is you're up moving around, you're on your liquids, you're on your protein supplements, and you're seeing if you have any nausea or any post-operative things that are going to slow you down, because we want to make sure you go home and you're able to be successful. Patients typically follow up within the first to second week. You see the surgeon. And then activity-wise, it's kind of in that 2 to 4 range for the majority of surgical procedures. The lap band's a 1 to 2, and that's lifting, physical activity. Restrictions initially after surgery, no lifting, pushing, or pulling greater than 10 pounds for that first 2 weeks. Okay. Results expected. So the majority of patients, like I said, with the SATI, it's a more complicated procedure. We expect almost 75 to 80% of excess weight loss. Roux-en-Y gastric bypass is about 60 to 70%. Sleeve gastrectomy 50 to 60, band about 40%. So usually when I talk to patients in the office, a lot of the times the numbers that I quote, because excess weight loss is kind of hard for a patient to kind of understand. So I usually typically tell patients the SATI, you can expect anywhere from 10 to 15 BMI points off your BMI. Roux-en-Y gastric bypass is kind of that 10 to 12. Sleeve gastrectomy is typically 8 to 10. Do you qualify for surgery? All right, so typically this is for patients who have BMI between 35 and 39 with one or more weight-related health conditions. Those included are diabetes, sleep apnea, high blood pressure, or high cholesterol, or you have a BMI over 40 with no additional weight-related health conditions necessary. You have to be at least 18 years old here. We don't operate on pediatric patients. Medically and psychologically cleared for surgery, because again, we want to make sure that you're doing this for the right intentions and you're not going to have any destructive behavior that's going to sabotage you. And then there are some insurances that do cover BMIs lower than 35 with specific health conditions. All right, so that's something that is worthwhile. If you don't know, check in with your insurance company. Again, we review, you want to review your insurance policy to make sure bariatric surgery is covered benefit. Does your insurance plan require documented dieting history? And that will kind of determine how quickly you're going to have surgery. All right, so that kind of determines. Some insurance companies require 3 months, 6 months, or 12 months of documented dietary history and weight checks. They want to see at least a trend towards losing weight before they approve you getting surgery. And we also have insurance specialists available here in the clinic that you will see on your consultation day to help you guide you through the process and make sure that you're keeping up with everything. Why choose Hurley? Why choose Hurley's Comprehensive Weight Loss Center? The experience, again, we performed over nearly 6,500 bariatric procedures. We originally opened in 2000, obviously till now. We are an accredited, comprehensive bariatric center of excellence, which helps assure our quality. We submit all of our data and they look at our data very closely. We make sure that obviously we are abiding. We don't have any extremes of complications or anything like that. We have a great team approach. Obviously, Jennifer and Hannah and everybody here speaks to that. We offer a comprehensive preoperative and postoperative care program with experience both the surgeons, the nurse practitioners and PAs, the dietitians, the medical assistants and the nurses, and the insurance specialists. And you see all of them in your first appointment. And then we have support groups, free monthly support group that is open to pre- and postoperative surgery patients. And I have a lot of patients that are 2 years out and they still come to the group because it holds them accountable, and that's a lifelong change that they want to continue. And that's what we offer here. Hannah's going to come up and go through the dietary changes.
Hello, I'm Hannah. I'm one of the dietitians here at the clinic. So like Dr. Wong said, I'm just going to go over some of the dietary changes that you can expect after bariatric surgery. If you have any questions, just feel free to ask. So, first thing for you, like I said, you can expect to have some dietary changes after surgery. Your diet after surgery will progress in stages. So typically that happens once you are 2 weeks post-op, 4 weeks, 6 weeks, 8 weeks, and then 12 weeks post-op. You will come to both pre-op and post-op classes. During those classes, you actually meet with the dietitian, and we will teach you how to progress your diet during that time. First, you can expect a change in the way that you eat and drink. After bariatric surgery, you cannot eat and drink at the same time. So you actually have to wait 30 minutes between all food and fluid intake. In addition to that, you'll have to have a slowed rate of eating. Your stomach after surgery is so small, you can only put so much in there at one time. So we just delay your rate of eating over a longer period. Second, you will have changes in the type of foods that you are consuming as well. After bariatric surgery, we do not recommend that you consume any carbonation. So no soda pop, no sparkling water, sparkling juices, or anything of that matter. In addition to that, we will also limit your caffeine intake, but these are all things that you will also learn once you get closer to surgery as well. Like Dr. Wong had kind of mentioned, with your food choices after surgery, we have to pay a lot of attention to the amount of fat and the amount of sugar that we're consuming. So you will see after surgery that we are going to avoid certain types of food, such as processed foods, fast foods, convenience foods, and things of that matter. Lastly, again, it's just the amount of food that you're going to be eating. Like I mentioned, and like Dr. Wong had mentioned as well, your stomach is so small, we can only put so much in there at one time. So your portion size is definitely very small after surgery, but as we progress your diet, we will teach you about this after surgery. Over time, we slowly increase that portion size, but it will definitely be smaller compared to what maybe we are currently consuming. Long-term diet after surgery. So typically the average calorie intake for patients after surgery is anywhere from 1,000 to 1,200 calories. Right after surgery, you will definitely not be consuming that full amount. But again, as we progress your diet, we will slowly work you up to that amount. And then once you actually hit your goal weight, you can speak with a dietitian and we can talk to you about weight maintenance and anything like that. In terms of protein, so if you do choose to move forward with surgery, you will hear at every single appointment, we're going to ask you, what's your protein intake? How much protein are you getting in? Protein really drives weight loss after surgery. So again, you will learn more about this. However, on average, patients are typically consuming anywhere from 60 to 80 grams of protein per day. And then as time progresses after surgery, we typically increase that amount as well. In general, like I kind of mentioned, your food choices after surgery, we're going to avoid things that are higher in fat and higher in sugar. We're going to chew our food very well. Like I mentioned, we're going to have a slow rate of eating. Typically, I tell patients that mechanical digestion that happens in your mouth is very helpful for the chemical digestion that's going to happen in your stomach. When it comes to the eating and drinking, like I mentioned as well, we're just going to avoid eating and drinking at the same time. When it comes to vitamins and minerals are going to be a lifelong requirement after bariatric surgery. Again, once you get closer to surgery, likely one of the dietitians, we will be teaching you more about those vitamins and minerals, but that is something that you should expect in the future as well. So, some financial commitments that come along with bariatric surgery. Every patient that has surgery with us here at the Weight Loss Center, they are required to purchase a pre-surgery liquid diet kit. You follow that for the first 2 weeks prior to surgery. It's basically to shrink your liver. Your liver is located next to your stomach. If we can shrink your stomach a little bit, it allows the surgeon to perform the surgery on you just a little bit easier, a little bit safer for you as well. That price is right around $200. It's a one-time expense. Again, we will give you more information about that in the future. When it comes to your protein supplements, so with your decreased stomach size and the amount of food being smaller as well, we rely really heavily after surgery on protein shakes. So you can expect around $50 a month or so on protein shakes after surgery, as well as those vitamins and minerals as I talked about. There are a couple of different options of those, but typically that ranges around $50 per month for your vitamins and minerals as well that you will have to take. So, what can you start doing now? There are certain behaviors that you can start implementing just to implement a more healthy lifestyle for yourself. First thing we always recommend is initiating some type of exercise, whether that is going for more walks throughout your day, reaching out to a personal trainer, whatever it may be. Exercise can look different for everybody. Eating regular meals. We find a lot of our patients tend to skip meals throughout the day, and one of the first things that you'll hear from the dietitian is to make sure that you're eating consistently throughout the day to support your metabolism. So eating regular meals, not skipping meals. Focusing on your food choices. So making sure you're choosing lean protein sources, focusing on your vegetables, your fruits, choosing whole grains, avoiding the fast food and the processed foods, as I had mentioned, drinking plenty of water, and then practicing environmental control. I always say out of sight, out of mind. If the food isn't in your house, we're less likely to be eating those options. So, sounds great. Now what are the steps moving forward? First step would be to make a consultation appointment with one of our surgeons. So you guys obviously met Dr. Wong today. Our other two surgeons here at the clinic is Dr. Farhan and then Dr. Shashwani as well. At that initial consult appointment, again, as Dr. Wong had briefly mentioned, you will meet with the surgeon that day. You also meet with the dietitian. You will meet with the nurse, medical assistant, and the insurance specialist that day as well. Patients always want to know how long is it going to take after their consult appointment to have or be scheduled for bariatric surgery. I do always point out to everybody, and I'd like everyone to know, we as a clinic require that we see all patients for at least 3 months before surgery. However, the length of time that it will take is largely driven by insurance, as well as the patient and their readiness and willingness to make certain changes prior to surgery. Certain things that we do have to kind of wait on. So certain requirements would be your psychological evaluation. All patients that have bariatric surgery have to undergo a psychological evaluation, certain diet documentation, as well as clearances. So medical clearance, possible cardiac clearance, pulmonology clearance, maybe nephrology clearance. It just kind of depends on your past medical history. We will also request records and medical clearance from your primary care provider. So those are also things that we would be waiting on, as well as once we submit to your insurance. Certain insurances take a little bit longer to get back to us with a certain answer, so that might be something that we have to wait on as well. Couple of other important things to know. Smoking. After bariatric surgery, you cannot smoke. If you are currently smoking, you must stop for at least 2 months prior to surgery, and that is something that we will test for as well. Smoking is dangerous after surgery due to the following reasons. First of all, it can lead to poor healing after surgery. Dr. Wong showed you where those staple lines will be. If you're smoking, it can impact that healing. You're at an increased risk of infection and also an increased risk of stomach ulcers, which can lead to a perforation, which is basically an opening along that staple line and whatnot. If you are currently smoking, we always recommend that you start working with your primary care physician now to start a smoking cessation program. Next up would be alcohol. Alcohol is not recommended after bariatric surgery for a couple of reasons. First of all, the changes in your stomach and your intestinal tract. Alcohol can pass the blood-brain barrier very quickly after surgery, so intoxication can happen very fast. So we always tell patients to avoid it. Second of all, alcohol, just the empty calories that are involved with alcohol and the damaging effect that it can have on your liver. It's another reason why we always recommend avoiding alcohol after bariatric surgery. Last thing would be pregnancy. A healthy pregnancy, it is possible after bariatric surgery. However, we always recommend that if this is something that you're thinking about, that we wait at least 18 months after surgical procedure. That's not only related to the hormonal changes after surgery. However, from my standpoint, I want to make sure that your nutritional status is at a good spot to be able to support a healthy pregnancy. Weight regain. So, weight loss surgery is not the cure-all for obesity. It is possible to regain some or all of the weight that you had lost after surgery. We typically see if patients come back after surgery and they are gaining weight, typically it's because they are readopting some of those poor eating or drinking lifestyle habits. We do have post-surgery exercise education classes as well as nutrition counseling with our providers, the dietitian, that if that was the case, 100% we can help you with that. Last thing that I want to point out tonight, so bariatric surgery, it's not just a quick fix as I think a lot of people see it as. It is a lifelong commitment. Long-term success with weight loss, it's a marathon, it's not a sprint. You will encounter hurdles along the way. Expect them, plan for them to overcome them. Just keep on going. I tell every single patient, we're here to help you and we want to help you.